The second type of information that you will fill in is Form A, patient data. When you are doing data collection on a ward, almost all of your patients will be eligible to participate in the PPS, and therefore all of those patients will have a Form A filled in. There are certain examples, and the protocol clarifies this. For those patients that are not taking antimicrobials and do not have an active HAI, you will fill in only the left side. For those that have either an antimicrobial or active HAI, you will fill in both the left side and the right side. We will begin by the hospital code. This is obviously the same type of code that was used on Form H. In our case, we only had one hospital with one site, and the TTP code was 123. Therefore, we are doing data entry for 123. Next is the ward name. This is the same as the ward code on our ward list. In other words, this is the code that your hospital describes to this particular ward. The next field, ward specialty, is the code for this ward that you find in the code book. Next is the survey date. This is the day on which data collection was done for this particular ward. In our case, the 8th of August. The patient counter deserves some more attention. In a hospital, you will be using a patient internal code, but this very often uses some type of personal data. For instance, some hospitals use A and B for male or female, including then the date of birth, with the year, month, or day, and some letters of the name. This data cannot be entered into the PPS because it must be completely anonymous. Therefore, it was decided to work with a patient counter. Every one patient internal code has one unique patient counter. In other words, if you were to make a list of all the patient internal codes that will be participating in the PPS, you will have, for one of these patient internal codes, a unique patient counter. You could either make this list while you are doing the PPS and write down on your list what patient internal code you are doing at that moment, and then write down the patient counter on Form A, or you could write the internal patient code on the form and generate a patient counter later when you are doing data entry. In other words, there are two possibilities. Either you give the patient a patient counter when you are doing data collection and you write this on Form A, but you also keep a list. Or you will write down the patient internal code and you will not yet make a patient counter, but will make this the moment you are doing data entry. When you are doing data entry, you will then also need to create a list that combines patient code with patient counter. We filled our example for an 80-year-old male that was admitted the 22nd of July 2011. The consultant patient specialty is a specialty of the physician who is treating the patient, and this can be completely different from the ward specialty. For instance, our patient is on ICU 1, but may very well be treated by an infectiologist. This is the place to clarify that. The codebook will be the same for these two. Here are the risk factors that we were talking about. The standard version means that you will be using all of these risk factors per patient. This allows for a standardization of these risk factors of your HAI and will make comparison between the hospitals far more interesting. A hospital that has many patients that have just had surgery since admission will be a different type of hospital than a hospital where no patients had surgery since admission. A hospital with many vascular catheters will be a different hospital than a hospital with no central vascular catheters. Surgery since admission is either none, NHSN surgery, or minimal invasive non-surgery unknown should be avoided. The difference between NHSN and non-NHSN surgery is clarified in the end of the codebook. The second risk factor is the McCabe score. This will be a score that many of you are unfamiliar with. It mainly describes the life expectancy of the patient. Non-fatal disease is expected to survive more than 5 years. Ultimately fatal is expected to die within 1 to 5 years, and rapidly fatal is expected to die within 1 year. This is an interpretation, an estimation, that the treating physician of that specific ward will make of that patient. It is important to understand that this McCabe score should be scored without the current HAI. In other words, if the patient has a pneumonia that is not an HAI, the pneumonia can be taken into account for the life expectancy of the patient. However, if the pneumonia is an HAI, then the pneumonia should not be taken into account. The protocol gives some examples for the different categories of the McCabe score. Next, you will mark whether vascular catheters were in place, a urinary catheter, and if the patient was. The last two questions, does patient receive antimicrobials, are clarified under the table, as is the question, patient has active HAI. If either of these two questions is marked yes, you will proceed to fill in the right side of the form. The top describes the antimicrobial use, and the bottom describes the HAI. For antibiotics, there are 5 variables. The generic name, and please mark that although this says or brand name, this is not the case. The current version of Helix Winnet can only code generic names, so we advise you to already fill in the generic name here. Next, route and indication are clarified under the table, but more extensively in the protocol. The diagnosis can be found only in the codebook, and in our example would be pneumonia, PNEU. And the last variable is whether or not the reason for giving antibiotics is described in the codebook. In other words, did the physician write down why he has decided to prescribe antimicrobials? If the patient is taking several antimicrobials, you will begin a second or third line. It might be interesting to note here that the indication can be described as curative, prophylaxis, or other. In the case of surgical prophylaxis, the definition of is the patient on antimicrobials differs a little bit, and we will draw your attention to this during the presentation on the 8th of September. Next, we will talk about the HAI. The first field is the code of the HAI, which you will find in the codebook. In our case, the patient has a pneumonia type 1, which can be found in the codebook as being coded as PN1. The next question is whether there was a relevant device in situ before onset. This question should only be answered for certain HAI codes. For pneumonia, you should look whether the patient was intubated 48 hours before onset. For bloodstream infection, you will look whether the patient had a CVC or a PVC 48 hours before onset. And for a urinary tract infection, you will see whether the patient had a urinary catheter in the 7 days before onset. These are the only 3 HAIs for which you will fill in whether there was a relevant device in situ before onset. The next question is whether the HAI was present at admission. In our case, we decided to answer no. In that case, you should estimate a date of the onset of the HAI. If you answer yes, you do not need to fill in a date. Next is the origin of infection. Theoretically, only the 2 first are possible, because an HAI in the HAI part is defined as a healthcare-associated infection that was acquired in an acute care hospital. In other words, another origin is not really a possibility in the HAI, and you should reconsider whether your HAI really fulfills the HAI criteria of the PPS. Now you should fill in the source of the BSI. Obviously, you only do this if the case definition code is indeed BSI, a bloodstream infection. This may also be the time to mark that A special type of BSI is CRI3. This is a bloodstream infection that is catheter-related with microbiological proof. For this particular type of BSI, you do not need to fill in the source. In fact, you cannot fill in the source because in the HAI code CRI3, it's already clearly described what the source is, being the catheter. Last, you will fill in the microorganisms. We had to fill in Staphylococcus aureus, and the codebook described that this was this code. Next, for certain microorganisms, you also need to describe the resistancy pattern. This is not the case for all microorganisms, and the codebook contains a table where for each of these particular microorganisms you can find what their resistance code is for particular antibiotics. If you do not have a second HAI in this patient, you have now finished with the HAI form. Therefore, you have finished with the patient form. In the next presentation, we will now show you how to input data of Form A and Form H into Helix WinNet.